يا الله، بسم الله الرحمن الرحيم. صوتي مسموع أساتذتنا؟
اي دكتورة صوتك واضح، تفضل.
مسموع الصوت.
بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العلي العظيم. نجدد الترحيب بضيوفنا الكرام وبالسادة الباحثين المحترمين المشاركين في المؤتمر العلمي الدولي الثالث الذي تقيمه جامعة الكفيل. السلام عليكم جميعا ورحمة الله وبركاته. وعلى بركة الله تعالى أدعو الأستاذ الدكتور مصطفى غازي العباسي المحترم ليكون رئيسا لجلستنا البحثية الثانية مصحوبا بأسماء آيات الترحيب. والأستاذ الدكتور مصطفى غازي العباسي غني عن التعريف، وهو أستاذ خريج كلية الصيدلة جامعة بغداد عام 1993، ماجستير أدوية وسموم من جامعة بغداد كلية الصيدلة عام 2002، دكتوراه أدوية وسموم من جامعة بغداد كلية الصيدلة عام 2007، حاصل على شهادة التدريب في التعليم الحديث والبحث العلمي عام 2012 من جامعة لوليو السويد، حاصل على لقب الأستاذية في الأدوية عام 2015، أستاذ في جامعة الكفيل كلية الصيدلة، إعارة خدمات من الجامعة المستنصرية، شاغل لمناصب إدارية وعلمية سابقة أهمها عميد كلية الصيدلة الجامعة المستنصرية، معاونا للعميد للشؤون العلمية والدراسات العليا، رئيسا لفرع الأدوية والسموم، حاصل على لقب استشاري في وزارة الصحة عام 2017، عضو البورد العربي والعراقي للصيدلة السريرية، ناشر لأكثر من 60 بحث في مجلات عالمية رصينة، مشرف وممتحن لطلاب البورد العراقي والدكتوراه والماجستير، عضو دائم في اللجان الوزارية للتعليم العالي والبحث العلمي. كما أدعو المدرس الدكتور سالم فايز كاظم المحترم ليكون مقرراً للجلسة مصحوباً بوافر الترحيب. والدكتور سالم فايز هو خريج كلية الصيدلة جامعة الكوفة 2005-2006، حاصل على ماجستير في الأدوية والسموم من كلية الطب جامعة بابل عام 2013، حاصل على دكتوراه للأدوية والسموم من جامعة ليستر المملكة المتحدة، مدرس دكتور في جامعة الكفيل كلية الصيدلة، زميل شرفي جامعة ليستر المملكة المتحدة، عضو جمعية علوم الأعصاب البريطانية، عضو جمعية علوم الأعصاب الأوروبية، عضو جمعية التخدير والألم البريطانية، له بحوث منشورة في مجال الألم والالتهاب. ويتفضل الآن السيد رئيس الجلسة الأستاذ الدكتور مصطفى غازي العباسي المحترم لإدارتها مشكورا. تفضلوا جناب الدكتور.
شكرا دكتورة ياسمين على التقديم، شكرا جزيلا. بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على أشرف الخلق سيدنا محمد وعلى آله الطيبين الطاهرين. السيدات والسادة الحضور، الضيوف الأكارم، السلام عليكم ورحمة الله وبركاته. يسعدني أن أفتتح الجلسة العلمية الثانية للمؤتمر الدولي الثالث لجامعة الكفيل، حيث سيتم تقديم 9 بحوث يستغرق كل بحث 15 دقيقة زائدا 5 دقائق لإجابة استفهاماتكم من قبل الباحثين. نستقبل أسئلتكم ومداخلاتكم من خلال الكتابة في صندوق المحادثة. Ladies and gentlemen, the honorable guests, good evening. I am pleased to open the second session of the third international conference of University of Al-Kafil. You all welcome. For further inquiries, please write down in the chat box. Now, may I call my colleague, Dr. Salim, to read the CV of Dr. Ghazal Fatima.
Thank you, Professor Mustafa. Dr. Fatima is assistant professor in the Department of Biotechnology, Era University in India. She is life member and fellow of International College of Nutrition, life member of International Society of Chronomedicine, executive board member of International Society of Health Education, and member of Public Health and Community Medicine Board. Thanks, Dr. Muslim.
Thank you very much, Dr. Salim. Dr. Ghazal Fatima her study talk about the vitamin D implications in COVID-19. Let us start with the first speaker, Dr. Ghazal. Fatima, now it is the time for you, Dr. Ghazal. Dr. Ghazal. Dr. Ghazal, please open the microphone.
Yeah, my phone is open. First of all, I would like to thank the committee for inviting me to present my work here in this very well-renowned conference. And I would request the organizers to please play my slide so that I may speak. I have sent the PowerPoint presentation. Or shall I open the slide share?
Okay, go on. Go on.
You can.
Okay. If you would open, it would be easy for me.
I can do that for you if you want.
Okay. I may. Yes, just give me.
Would you like me to do that?
No. I'll open. Can everybody see this? Is this clear? Okay.
Yes, it is clear, doctor.
Okay, thank you so much. Now, I would speak on vitamin D implications in COVID-19. And first of all, I would like to tell everyone that vitamin D is a core need vitamin that we need for our bone absorption. And that is very much crucial for our health. That is very much crucial for the absorption of calcium present in our body. So vitamin D in its inactive form, that is vitamin D3 or cholecalciferol, is a steroid hormone that is synthesized in the skin itself with adequate exposure to sunlight. And it's also acquired from our diet and from vitamin supplementation. Vitamin D is considered deficient when serum hydroxy vitamin D levels are less than 10 nanogram per ml, insufficient when serum levels are 10 to 30 nanogram per ml, and optimal with serum levels greater than 30 nanogram per ml. Additionally, vitamin D is a key player in bone growth and metabolism that we all know. Cognitive function, it helps in cognition, also in remembrance, in boosting up memory cells so that our memory works proper, and cardiovascular health, as well as health of respiratory tract, skin, and also fight against any viral or bacterial infection in our body. The fascination with vitamin D supplementation began with the discovery in the early 1920s that vitamin D prevented rickets, and was also further driven by the recognition of other potential roles of vitamin D in non-skeletal outcomes, including immune function, cardiovascular health, and also cancer. However, the data on the function of vitamin D in bone growth and maintenance is clear-cut and has informed practical clinical guidelines and public health policies over the years. Additionally, increased time spent indoors due to a strict lockdown and shielding triggered concern that some people might not obtain the necessary physiological level of vitamin D from the sunlight. Because during the COVID condition, everybody was locked in their houses. Most of the people lives in the apartment where there is no sunlight, only, the small windows are there. So that also triggered the sunlight reaching into the houses or reaching into the skin. The exposure was very less. Vitamin D receptors are highly expressed in B and T lymphocytes. That is very much important in inflammation, suggesting a role in modulating innate and adaptive immune responses. The renin-angiotensin system, exaltant with consequent inflammatory response, has a leading role in the pathophysiology of vitamin D infection, and it may be downregulated by vitamin D and melatonin in many organs. Vitamin D levels reach their nadirs at the end of the winters, and low levels are associated most of the time with increased risk of acute respiratory tract infection during winters, and are mitigated by the fact that supplementation of vitamin D during those times may soothe up the function, and clinical trials involving vitamin D supplementation in COVID-19 are ongoing, and few are almost completed. We are also doing vitamin D receptor gene polymorphism in our hospital of severe COVID-19 patients. So here, this figure represents very nicely that hydroxyvitamin D levels in nanogram per ml, that moderate levels in COVID-19 was found in between 20 to 30 nanogram per ml, whereas severe critical condition in COVID-19, ICU admitted COVID-19 patient, vitamin D levels were less than or equal to 10. That was, less levels of vitamin D was found in ICU admitted COVID-19 patients. So that triggered not to fight the infection, and the severity of symptoms increased. And vitamin D3 has a very putative roles in elderly and also in COVID-19 because it's pro-immune function, and it exhibits the anti-storm of cytokines. So these are the most important and things to remember of vitamin D levels. So the COVID-19 pandemic remains a major public health threat in most of the countries all around the world. Not even in most of the countries, it's all around the world, and everyone is exhausted and exhausted by this condition. The causative severe acute respiratory syndrome by coronavirus can lead to acute respiratory distress and results in mortality in COVID-19 patients. So vitamin D is an immune modulator hormone with established effectiveness against various upper respiratory infections. Vitamin D can stall hyperinflammatory responses and expedite healing process of the affected areas, primarily in the lung tissues. This is the most important thing, and this is the most helpful thing, because vitamin D is low cost. That is just a vitamin that is exalted in our body and it's soothing our body. Thus, there are ecological and mechanistic reasons to promote exploration of vitamin D action in COVID-19 patients, as no curative drugs are available currently for COVID-19. We feel that the potential of vitamin D to alter the course of disease severity needs to be further investigated. And one thing I will add here, apart from this presentation, that we got vaccinated by COVID-19. A doctor from our institution got COVID shielded, vaccinated twice. He got 2 doses of COVID-19, but still the virus hit him again. So it's like we cannot even trust the vaccines also. Vitamin D immune system and SARS-CoV-2 are having a very close relation, because the alveolar and the B and T lymphocytes, their levels are triggered by high levels of vitamin D, and their level gets, the inflammation gets increased when there is low level of vitamin D in the patients. I'm not just talking about right here about COVID-19, but still, if a person is having painful alveoli, a person is having painful COPD, he's coughing and he's feeling pain in his chest. So we have studies in our institution that constant supplementation of vitamin D along with calcium relax the patients so much than any other drugs did. So over here, the vitamin D immune system and SARS-CoV-2 relation is not really very clear, because the mechanism of action, 100% mechanism of action is not clear. However, the work is still going, and some of the papers have presented the work, but the mechanism of action, nobody has shown the mechanism of action, but we can explain it by the other pulmonary diseases And let's see, in the coming years, we will know the exact mechanism. It is an immune booster. It is also an immune booster. Vitamin D or calciferol is a fat-soluble vitamin. So it gets soluble in the fat. So it's found in certain fish, meat, almonds, and dairy products. It's most of that, most important thing over here, I'll say that vitamin D is present in sardines, salmons, and naturally occurring, the tuna fishes have maximum amount of vitamin D. 240 international unit is present in tuna fishes. It is also produced when ultraviolet rays from sun strikes. However, I never say go for this sunlight to take the exposure to take vitamin D, because that also causes skin cancer. So the sun is very harsh in the summertime, and even in winter time, sitting for so long in the sun. However, it's very controversial, so I'll not go deep into this. As it relates to COVID-19, one of the most important role vitamin D can play is in the inhibition of cytokine storm caused by the innate immune system reactions to SARS-CoV-2. So this is the basic thing which we can say just by giving the supplementation to the patients of coronavirus. This is the most important thing, because we have tested in all the inflammatory cytokine like interleukin 1, interleukin 6, interleukin 18. And we found that in COVID patients, their all levels were very high. Interleukins, the cytokines, inflammatory cytokine storms were high. However, after giving supplementation for 8 to 12 days, they were found, normal, or the slight down regulation of inflammatory cytokine. Vitamin D reduces the expression of pro-inflammatory Th1 cytokines such as tumor necrosis factor alpha, interleukin 1, interleukin 6, interleukin 17, and interleukin 21. In addition, vitamin D upregulates anti-inflammatory cytokines such as interleukin 10. And among 134 patients hospitalized with COVID-19, 90% of ICU patients had a vitamin D level more than 50 nanomole versus 39.1% of non-ICU patients. ICU patients were more likely to have hypertension, a higher baseline respiratory rate, and higher C-reactive protein levels that we all know. That C-reactive protein was found higher in COVID-19 patients. No association was found with COVID-19 mortality.
You have only 2 minutes, please.
Okay. So I'll compile it. I'll go into a very short. In a single center retrospective study, Panagiotto and colleagues analyzed data from 134 patients who tested positive for COVID-19 and had a serum 25-hydroxy vitamin D levels measured on admission. Researchers assessed the prevalence of vitamin D deficiency, compliance with local treatment protocol, and the relationship of baseline serum hydroxy with markers of COVID-19 severity and mortality rate. That is, it is associated with severity in COVID-19 patients, the less level of vitamin D. I'll not go with this. As we have very less time. So as I have already explained, the many authors have concluded that vitamin D supplementation might be an inexpensive and light mitigating of SARS-CoV-2 pandemic. So it's a must to include vitamin D in your diet. Why to get coronavirus? Why not get previously tested, and why not start supplementations of vitamin D? And most important thing, I have given some message in the conclusion, so I'll here conclude my presentation. Current public health guidelines for optimizing vitamin D status should be followed always, and clinical data from systemic reviews and meta-analysis shows benefit in the prevention of respiratory infection and improvement of pulmonary function. Patient hospitalized with COVID-19 should have baseline serum hydroxy concentration measured and should be supplemented to a level more than 30 nanogram per ml. That is optimal to 40 to 60 nanogram per ml, especially when the baseline level is less than 10. This is the most important thing. And in COVID-19 patients with vitamin D concentration under 20 nanogram per ml, the recommended dose for correction of deficiency is 6,000 to 7,000 oral international unit per day for 6 to 8 weeks. For maintaining the dose, that varies from 2,000 to 3,000 oral international unit per day, depending on the age and clinical condition of individual up to it reach to its optimal concentration. A final message based on all the practical issues discussed: keep the vitamin D serum concentration during all the year between 40 and 60 nanogram per ml. It is one of the fundamental care to reduce at least the risk of RTIs, and that is included. And takeaways: vitamin D levels above adequate may reduce risk for contracting COVID-19, and adequate versus higher vitamin D levels was associated with 2 to 3-fold increased risks for COVID-19. And these are the references, and thank you so much. If any questions, they are welcomed. Thank you so much for the patience hearing. And have I completed in time?
Thank you.
Dr. Salim?
Thank you.
Yes, thank you very much. A couple of minutes more.
Very much.
Thank you so much. Thank you so much. I tried to complete it in time. However, I was told that...
May I ask you one question, please?
I will be pleased to answer.
Why did COVID-19 causes dramatically decline in India? Do you have an idea about the reason of this issue?
COVID-19 is having decline in India.
Again?
No.
Why did COVID-19 causes dramatically decline in India?
COVID-19 is not decline in India. It's now increasing fast. Previously there was no cases in this December, January, February. There was not a single case in my hospital. And now from today, 20 new admissions have been done for COVID-19, 20 new admissions of COVID-19 patients, 20 new patients, and in Lucknow itself, where I live, 145 new cases detected. So it's increasing very fast. Previous year, 2020 ratio was even very less than this year's. Now this is, the symptoms are also very critical, and it's extremely contagious this time, and it's increasing very fast. Most important thing is, it's increasing very fast, maybe because people are not wearing masks. Now they think that it's gone. COVID-19 is gone. But again, a daily new 145 and 149, and it's increasing like anything. And everybody got vaccinated.
Thank you very much. Thank you very much, Dr. Ghazal. We hope that the pandemic started to burn itself in all the world. We hope.
Yeah,
we
can
so.
only pray God. Only God can now help us to get rid of this COVID-19.
To present about the study influence of climate and geographic conditions on body length.
Do you hear me, please?
Dr. Vajte.
Dr. Vajte, did you hear me?
الدراسة مالتها عن الانفلونس of climate and geographic conditions in Kyrgyzstan. Dr. Wajdi.
Can you hear me?
Dr. Wajdi, did you hear me?
Yeah.
Okay.
I hear you.
Thank you, Dr. Mustafa. Dr. Wajdi Jum'a Muhammad Al-Awaida is an assistant professor in biochemistry and molecular biology. He had bachelor in biology, MSc and PhD in biochemistry. And since 2013, He is an assistant professor and head of department of biochemistry and molecular biology. Please start your presentation, Dr. وجدي.
شكرا لجامعة الكفيل، وشكرا للجنة المنظمة لهذا المؤتمر، وشكرا لقبول البحث والدعوة لإعطاء برزنتيشن، وشكري الموصول برضو للبروفيسور الأستاذ الدكتور نجاح هادي على دعمه المتواصل والتعاون المتواصل. Share my presentation. Our research about influence of climate and geographic conditions on body length of male newborn in Kyrgyzstan. I'm Dr. Wajdi Awaida, Department of Biology and Biotechnology, American University of Madaba, Associate Professor in Biochemistry. This article prepared by authors from different countries as listed in this slide. Now, Kyrgyzstan, which occupies a total surface of 199,949 square kilometers, is landlocked country in Central Asia. It is bordered by Kazakhstan to the north, China to the east and southeast, Tajikistan to the southwest, and Uzbekistan to the west. The provinces Batken, Chai, ISCKU, Jalalabad, Nurn, Osh, and Talas are the main regions of this country. Now, this area of country, as we said, 199,949 square kilometers. 90% of this area is above sea level. The northerly and southern zone are divided by mountains. The climate for this country is dry and continent, as shown in this figure. Now, monitoring the state of children health and establishing a cause and effect relationship between the quality of the environment and the health of children's demographic population is worth investigating. A strongly anthropometric indicator of physical development is the weight and length of the body at birth. During the growth and development of the organism, the implementation of the genetic program takes place in the external manifestation under the impact of environment factor. High altitude area display a complex ecology, which not only include physical condition, but also population demographics, socioeconomic factors, and access to healthcare. Hypoxia frequently happen in combination with wide variation in daytime or seasonal temperature and extreme solar radiation. The pattern of genetic adaptation to high altitude hypoxia, such as blood flow increase and delivery of oxygen versus increased erythrocytosis, exists in multitude of indigenous population. Among different population groups, an inverse relationship between birth weight and altitude has been demonstrated. Lower birth weight is not the result of a premature birth, but of restricted intrauterine development. This decrease in average birth weight has been reported to about 100 gram per 1,000 meter elevation above 2,000 meters. In addition to birth weight reduction, there is indication that the length of crown heel and thickness of the skin are also reduced at high altitude. What our aim? The aim of this study was to investigate the effects of altitude of residence and ethnicity in Kyrgyzstan on the body length of male newborn in Kyrgyzstan between the year of 2003 and 2011. Now, this study was prepared by Institutional Review Board, Friendship University of Russia. Our study was carried out from March 2003 to March 2011 in many public and private hospitals at high and low altitude area in Kyrgyzstan. The body length of 3,359 male newborns was measured 2 hours after delivery by using stadiometer to the nearest 0.1 centimeter. Now, this table shows the different area with different altitude above sea level and different ethnic group in Kyrgyzstan. In the first line, we have mother's area of residence, the area of residence, Alay, Talas, Osh, and Aravan. The second line is ethnic group. We have 2 ethnic groups in Kyrgyzstan. We have Kyrgyz and Uzbek. The third line is altitude above sea level. From this table, okay, we have the highest altitude is Alay Highland. Then we have Alay Midlands. Alay Highlands about 2,800 to 3,500. Then we have Alay Midlands. Then we have then tell us 1,280. We have Osh with ethnic group about 940 to 1,070. Osh with Uzbek ethnicity, we have 940 to 1,070. Now, Aravan, the lowest altitude from 700 to 1,250 for Kyrgyz and 700 to 800 for what? Uzbek. And the fourth line, we have a number of male newborns. Now, what about results? This figure shows male newborns length comparison between different area with different altitude above sea level. From this figure, we have, or we will conclude, male newborn length of Alay Highlands, as we discussed, the altitude, its altitude about 2,800 to 3,500 meter above sea level. We have length, male newborn length about 50.15 plus minus 1.4 centimeter. Alay Midlands was 50.25 plus minus 1.3 centimeter. In a lower altitude area, such as Talas and Osh, male newborn has significantly greater what? Body length. For example, in Talas, body length about 51.94 plus minus 1.85 centimeter. Osh, 51 plus 41, 51.41 plus minus 1.77. From this figure, as the altitude increase, the male newborn length will be decreased. This table shows male newborn length comparison between the different area with different altitude above sea level. we have a significant level at b value less than 0.001 by using Tukes
Sorry, Dr. Wajdi, you have 2 minutes. Dr. Wajdi,
by
you have 2
Tukes
minutes.
multiple comparison test. Now, this figure shows there is no significant change between male and newborn length between two ethnic groups in Kyrgyzstan. Now, high altitude create a natural laboratory for the analysis of pathway responsible for hypoxia associated decline in the fetal growth. Chronic stress, such as long-term hypoxia, can directly affect fetal development because fetal growth is critically dependent on sufficient maternal oxygenation conditions such as high altitude residence or that of mothers who are moderate to severe smokers or have cyanotic congenital heart disease, pulmonary disease, severe anemia, and other conditions that cause extended hypoxia may be correlated with fetal growth restrictions. Preeminent residents who have been living at high altitude for generations demonstrate the genetic adaptation need to optimize cellular oxygenation. In addition, the adaptation of cellular response and tissue must be achieved through the short-term residents who spend a week to a month or more as visitor or mountain climbers. As many research results show, adaptation in those who are born and raised at high altitude show the maximum level of efficiency. The last slide is significant increase in male and newborn length as the altitude increase. It can be concluded that ethnic group differences in pregnancy outcomes reflect a better state of adaptation to high altitude. In this healthy indigenous population, and that long-term genetic selection may be the most possible explanation for these ethnic differences. Thank you.
Thank you very much, Dr. Wajdi, for your nice presentation. Do you have an advice for pregnant women in Kyrgyzstan? Do you have any advice?
There is no advice because we need genetic adaptation. The women in Kyrgyzstan, I think, have genetic adaptation to live in.
So how can we reduce? Sorry, how can we reduce the effects of high altitudes?
I think we can't. We can't reduce. We need more oxygen. We need area with more oxygen. Okay, our problem in oxygen, high altitude characterized by low oxygen.
دكتور مصطفى؟
تفضل دكتور.
ممكن سؤال دكتور وجدي؟
دكتور سالم.
تفضل.
تفضل دكتور سالم، تفضل.
العفو دكتور. انا عندي بنتي صارت في بريطانيا، انولدت في بريطانيا. ولما جتي لو بيرث ويت، فلما يعني سالت عن الموضوع لقيت انه اغلب الاطفال اللي اصلهم ميدل ايست لما يروحون لبريطانيا يكونون لو بيرث ويت، يعني حوالي 70% من الاطفال اللي هم اصلهم ميدل ايست يكونون لو بيرث ويت. فهل ممكن له علاقه الموضوع؟
المنطقه اللي كنتوا عايشين فيها قديش الارتفاع الالتيتيود تاعها؟
والله هي اعلى من لندن، بس ما متاكد ايش قد، بس هي اعلى من لندن.
ما هي اذا منطقه عاليه معناته فيش عندنا جينيتك ادابتيشن. وبالتالي هذا ينعكس على صحه الجنين. هم يعني الاثر عليهم اخف لانه عندهم جينيتك ادابتيشن مع الوقت. لكن انا لو اروح اعيش يوم او يومين راح انخنق عندهم، ما راح اتحمل.
احسنت.
انا يعني شبهوها كأن الام سموكرز، يعني بناء انه كميه الاكسجين قليله.
تمام، شكرا دكتور.
هلا دكتور سالم.
شكرا دكتور وجدي، شكرا على التقديم وشكرا على الإجابة على الأسئلة، وأهلا وسهلا بك. شكرا يا مرحبا.
يعطيكم العافية.
الآن الباحث الثالث اللي هو زميلي ماي كوليج دكتور سالم، اللي هو coordinator of the second session. دكتور سالم حاصل على شهادة البكالوريوس في الصيدلة من جامعة الكوفة عام 2006. لديه ماجستير أدوية وسموم من كلية الطب جامعة بابل 2013، دكتوراه أدوية وسموم من جامعة ليستر المملكة المتحدة، وزميل شرفي لجامعة ليستر في المملكة المتحدة، عضو جمعية علوم الأعصاب البريطانية، عضو جمعية علوم الأعصاب الأوروبية، عضو جمعية التخدير والألم البريطانية. لديه بحوث منشورة في مجال الألم والالتهاب، وهو من أحد المشاركين في تأليف الطبعة الأخيرة من سلسلة كتاب علم الأدوية. ليتفضل الدكتور سالم للتحدث عن دراسته اللي هي Nociceptions Counteracts the Effects of Lipopolysaccharide and Peptidoglycan and C6 rat astrocytes. تفضل دكتور.
Thank you, Doctor. Thank you, Dr. Mustafa. Assalamu alaikum. On behalf of my colleagues, Dr. Saif, Professor David Lambert, and Dr. John McDonald, I will start presenting our study, which is titled as Nociceptin Counteracts the Effects of Lipopolysaccharide or Lipopolysaccharide, depending on whether it's British or American, peptidoglycan in C6 rat astrocytes. Let's start with defining our main topics. Astrocytes belong to glial cells, which are surrounding neuron. So if we look at this image, this is the neuron. This is the astrocyte, which is the boss of glial cells with a wide range of functions. This is the oligodendrocyte, which are responsible for forming myelin sheets, and this is microglia, which is the central immune representative. In addition to the wide range of function that is performed by astrocytes, they are involved in several pathological conditions, particularly central pathological conditions. Nociceptin is the fourth member of opioid receptors. If we classify opioid receptors in classical, which are mu, delta, and kappa, there is another member which is discovered recently, is called opioid receptor-like, or is called nociceptin orphanine FEQ, and is referred to as NFEQ. They belong to a G protein coupled receptor, which is composed of 7 members, and it is called membrane receptors. Now, in our methodology, in a brief explanation, we used C6 rat astrocytes as cell lines, and we used inflammatory mediators to induce inflammation in astrocytes. We used lipopolysaccharide in a concentration of 10 microgram per ml, and peptidoglycan with the same concentration. In our treatment, so to study the effect of nociceptin in the inflammation that we produced by lipopolysaccharide and peptidoglycan, we used NFEQ, nociceptin, and its antagonist, which is UFP 101. Both were used at a concentration of 1 micromolar. In our assay, we used immunofluorescence to evaluate or to study the expression of TLR4 and TLR2, which are the receptors for LPS and peptidoglycan respectively. We used Western blotting to evaluate the level of protein that we are looking for, and we used calcium assay in English, which is produced intracellularly. In our result, so logically, and before starting our main project, we screened our cells whether they express TLR4 and TLR2 or not. Otherwise, anyone can argue and ask us if our cells express these receptors. So we did screening for TLR4 and TLR2 protein, and we found that our cells, C6 astrocytes, express both the TLR4, which is in red, and TLR2, which is in green. After that, we treated our cells with LPS, and we pre-treat the same cells with NFQ. So we found that this is the control. We found that this is the basic level of GFAP. GFAP is the glial marker, is astrocyte marker. So it is a specific marker expressed by astrocyte. In the resting state, in control, we found that GFAP is just the basal. When we used LPS, we found that LPS induce high expression of GFAP. That means astrocytes are activated. When astrocytes activated, they increase the expression of GFAP. When we use peptidoglycan, we found that GFAP is increased. When we added NFQ before LPS, we found that the level of GFAP is decreased. The same with PEPG. And then when we blocked the effect of NFQ by its antagonist, which is the UFP 101, we found that the level of GFAP is approximately the same for LPS and PEPG. The same for we did the same experiment for cyclin D1, which is a marker of proliferation of cells. So the control in the control state, in the resting state, cells expressed a considerable level of cyclin D1. When we added LPS and PEPG, they inhibited the expression of cyclin D1. The same when we added NFQ before LPS and PEPG, we found that the cyclin D1 level returned back to the approximately the control level. The same when we blocked. So we always block no NFQ with its antagonist to make sure that this effect is agonist-antagonist dependent. Pharmacologically, to refer the effect to the receptor, the effect should be reversed by antagonist. That's why we always use antagonist with agonist. The same for D3, exactly the same. So we found that LPS and PEPG reduce the expression of cyclin D3, and NFQ reverse the effect of LPS and PEPG. In terms of intracellular calcium release, we found that LPS induce the release of intracellular calcium. So the black line is the LPS, and when we added NFQ, the red line, we can see that the level of intracellular calcium returned to the basal level, while when we blocked the green one, when we blocked the N-13 with UFP, we can see that the level of intracellular calcium returned to approximately the LPS level. So this means that NFQ block the LPS-induced release of intracellular calcium. The same for peptidoglycan. So again, it induces the release of intracellular calcium, and the use of NFQ resulted in blocking of peptidoglycan effect. I don't like to expand my presentation, so I would just go through conclusion. We can conclude that the function of astrocytes is modulated by bacterial products. So this means that astrocytes can be involved, but are involved, actually, is not can be, are involved in an inflammatory process, and nostaceptin counteracts the effect of LPS and PEPG in terms of gliosis, glial activation, proliferation, and signaling. Another thing, glial cells are important players in inflammation. So from the previous 2 points, we can conclude that glial cells are important players in inflammation, and nostaceptin could be an important target in inflammation and inflammation-linked pain mediated centrally. So from these findings, we can conclude that astrocytes that express nostaceptin can be a good target for modulating inflammation, pain, and infection. Really thank you and happy to answer any question.
Thank you very much, my colleague Dr. Salim, for your nice, impressive presentation. Actually, I have 2 points.
Yes.
What would happen if astrocytes are damaged, and what are the main functions of astrocytes?
Actually, astrocytes have a wide range of function, like nutrition of neurons, support. These are the traditional function. Now, it has been clear that astrocytes communicates, affected by neurons and other glial cells. They release inflammatory markers, they release calcium, they modulate glutamate homeostasis, and they can release neuron modulating materials and affected by neurons released materials.
Thank you very much, Dr. Salim. Dear audience, you can write down questions in chat box, please. شكرا جزيلا Dr. Salim for your presentation. And now may I call شكرا جزيلا. May I call my colleague again, Dr. Salim, to read the CV of Dr. سعد رسول شاكر اللي حيتحدث لنا على ال cardiovascular manifestations of COVID-19.
شكرا دكتور مصطفى. دكتور سعد رسول شاكر حاصل على بكالوريوس في الصيدلة من كلية الصيدلة جامعة بغداد سنة 2000. حاصل على شهادة الماجستير في الأدوية والعلاجيات من كلية الطب جامعة الكوفة عام 2015، وحاصل على شهادة الدكتوراه في الأدوية والعلاجيات من كلية الطب جامعة الكوفة عام 2020. يتفضل الدكتور سعد مشكورا.
السلام عليكم ورحمة الله وبركاته. في البدء الله يحفظكم. في البدء أشكر كل من أسهم في نجاح هذا المؤتمر، ويشرفني أن أكون أحد الباحثين المشاركين في هذا المؤتمر. Now, at the first, I start with the title of our study review study, cardiovascular manifestation. Sorry. Cardiovascular manifestations of COVID-19 with a special reference of their treatment. Now, COVID-19 is caused by severe acute respiratory syndrome coronavirus 2, which have a crown-like morphology consisting of 4 structural proteins known as spike envelope membrane and nucleocapsid protein. As we know, with COVID-19 infection, there are many cardiovascular complications. We can summarize these cardiovascular complications as the following: venous thromboembolism, pulmonary embolism, acute myocardial infarction, acute cardiac injury, heart failure, myocarditis, arrhythmia, and shock. Through the direct or indirect mechanism, there are many complications with COVID-19 infection. These mechanisms include dysregulation of renin angiotensin aldosterone RAS system, endothelial cell damage and thromboinflammation, drug-induced cardiovascular toxicity, oxygen supply demand mismatch, physiological stress, cytokine storm, and finally, the viral toxicity. COVID-19 and AC2. As we know, the angiotensin converting enzyme 2 is a membrane-bound aminopeptidase, which have a major role in cardiovascular and immune system, which involve in heart function and in development of hypertension, diabetes mellitus. Also, the COVID-19 triggered by binding the spike protein of the virus to the angiotensin converting enzyme 2, which highly expressed in lung, heart, intestine, kidney. Now we're speaking about the clinical manifestation during the COVID-19 infection. There are many clinical manifestations. In lung, we can find the dry cough and dyspnea. In heart, we can find the cardiac injury, palpation, chestness. Intestine, we can find the diarrhea, nausea, anorexia, also the proteinuria and kidney in kidney. Angiotensin converting enzyme 2 wanted to counteract the angiotensin 2 from renin-angiotensin-aldosterone system and cardiovascular system by the binding of COVID-19 to angiotensin converting enzyme 2, prevent the enzyme from converting angiotensin 2 to angiotensin 1 to 7, which potentiate the effect of angiotensin 2 induced biological effect towards pulmonary and cardiovascular outcome. As we know, the naive angiotensin 2 offer a cardiovascular benefit or protection for cardiovascular system. This include anti-inflammation, anti-fibrosis, antioxidation, and vasodilation effect. Administration of RAS inhibitor, such as angiotensin converting enzyme inhibitor and angiotensin receptor blocker, upregulate the angiotensin 2, which is expected to promote the entry of COVID-19 and aggravation lung and cardiovascular injury in COVID-19 patient. There are many studies. One of the studies suggested that RAS inhibitor may enhance the pulmonary protection of AC angiotensin converting enzyme 2 and elevate the inflammatory response and cytokine release during the viral infection. Now, the cytokine storm. In patients with COVID-19 with cytokine storm are likely to develop multiple organ failure and sudden death. The syndrome of cytokine storm denoted a severe life-threatening condition manifested by sharp rise in pro-inflammatory cytokine, and also the hallmark of cytokine storm is an uncontrolled and dysfunctional immune response involved in continued activation of immune cells. These immune cells like lymphocyte, macrophage, and natural killer cells. These cells release abundant pro-inflammatory cytokine, such as MCP1, tumor necrotic factor alpha, macrophage inflammatory protein 1 alpha, interleukin 1, 6, 18, 7, 10, and interferon gamma. Reactive oxygen species accumulated under the cytokine storm to trigger apoptosis of the cell, mainly in infected area, which lead to degradation in extracellular matrix. Also, the protection of reactive oxygen species in face of cytokine storm move the immune system from protective to pre-injury state. Also, we noted that T helper 2 cells upregulated during the infection with COVID-19, which improve the overall cytokine balance and mitigate hyperinflammatory state induced by cytokine storm. During the COVID-19 infection, there are many agents used. Some of these agents can cause cardiovascular toxicity, such as chloroquine, cause QT interval prolongation, myocardial toxicity, also alter the cardiac conductivity. Another one is ritonavir, also causing prolongation and QT interval and high degree of atrioventricular block. Corticosteroid cause immune suppression, cardiovascular and metabolic disorder. Tocilizumab causes hypertension and increased serum cholesterol. There are many options during the infection with COVID-19 used to treat the cardiovascular complication, such as thrombosis, a targeting agent, RAS inhibitor, angiotensin converting enzyme 2 targeting agent, complement therapy, anti-rheumatic drug, and immune therapy. Heparin is one option used to treat thrombosis during the COVID-19 infection. Heparin conferred by 17 Spanish hospitals in the biggest retrospective study. Heparin have anti-arrhythmic activity besides its anticoagulant effect, and also it can counteract the physiological activity of a classical RAS. The other option is the thrombolytic agent, tissue plasminogen activator, which play a major role in life-saving many diseases such as myocardial infarction, ischemic stroke, pulmonary thromboembolism. And we have other options, antiplatelets such as aspirin, clopidogrel, and others, which play a role in enhancing the activity of anticoagulant. Finally, thank you very much for patience. العفو، أرحب بأي أسئلة، تفضلوا.
شكرا جزيلا دكتور سعد على هذا التقديم. أنا أشوف الشات بوكس ماكو أسئلة. أنا إذا تسمح لي عندي 3 أسئلة إذا ممكن حضرتك توضح لنا إياها.
نعم دكتور، تفضلوا.
واحد منهن إذا ممكن: is a bradykinin storm the cause of COVID-19 lung problems?
دكتور يقينا يعني احنا يعني نجي للنقطة الرئيسية اللي هو what did COVID-19 when entering the body. الو تسمعوني دكتور؟
The second one.
الو الو
إذا ممكن إعادة للجواب لأنه الصوت كان مو واضح.
نعم دكتور، عفو. احنا يعني نبدأ من النقطة الأولى أنه هو الانترنج اوف COVID-19 يعني هو المساعد إلى الانجيوتنسين كونفرتنج انزيم 2، وهذا بحد ذاته راح يزيد الانجيوتنسين 2. في هذه الحالة راح يسوي يعني اكتيفيشن لبرو انفلاماتوري ميدياتور اللي هو بحد ذاته راح يؤدي إلى المونوسايت اكتيفيشن ويزيد السيتوكين سكريشن. هذا كله راح يؤدي إلى السيتوكين ستورم والسلسلة اللي حكينا عليها، العفو، اللي هو يعني السلسلة مع الانفلاماتوري ميكانيزمز وايضا ثرومبوسيس والى اخره. الو.
What's your advice regarding patients treated with AC inhibitors?
دكتور الصوت مو واضح، عذرا. الو، الصوت مو واضح. الو.
Treated with AC inhibitors.
الو
دكتور مصطفى، لو السؤال العفو دكتور ما سمعه.
دكتور العفو، إعادة السؤال إن أمكن.
نعم دكتور سعد، what's your advice regarding patients treated with AC inhibitors? يعني we know AC inhibitors they are concerned with increase. Sorry.
نعم.
We know that the using of AC inhibitors, they are concerned with increased quinine level and pulmonary tree.
نعم.
So what's your advice regarding those patients? They have COVID as well. They treated with AC inhibitors.
دكتور العفو، يعني هذا الموضوع كونترافيرسي يعني، واكو بحوث كثيرة عليه، واكو suggestions، حتى اكو suggestions من الأوروبيان سوسايتي هايبرتنشن. الحقيقه يعني احنا تكلمنا عن موضوع الانجيوتنسين كونفرتنج انزيم، ويعني الى انه بالدرجه الاولى يسوي انترنج للكوفيد 19 الى السيل، وهذه تبدا السلسله. ولكن احنا لا ننكر انه دوره الفعال والاساسي كانتي انفلاماتوري من يشتغل على الانجيوتنسين ريسبتور 1 وكيف راح يؤدي الانتي انفلاماتوري انتي اوكسيدنت والى اخره. الحقيقه انا شخصيا يعني اؤيد انه استخدام الانجيوتنسين الراس انهبيتر، لانه احنا نحتاج الانجيوتنسين كونفرتنج انزيم، لانه نعرف انه الراس انهبيتر يسوي اب ريجوليشن للانجيوتنسين كونفرتنج انزيم 2. الو.
شكرا للإجابة دكتور، شكرا جزيلا.
دا اسمعك دكتور سعد، دا اسمعك.
نعم.
شكرا جزيلا، شكرا.
العفو.
دكتور سالم عندك سؤال؟ تفضل.
عفوا دكتور. دكتور تسمعني؟
دكتور سالم.
نعم دكتور وياكم.
دكتور سعد، بس بنقول كل الحاضرين هم يشتغلون على الكوفيد 19. هاي الثانيه كي بس لهم يعني.
لا عفوا دكتور. لا صراحة يعني كمؤتمر رائع، وأنا أشكر الكل الجميع صراحة يعني، وكوني واحد الباحثين هذا الشيء يشرفني بهذا المؤتمر العظيم. شكرا جزيلا لكم دكتور سالم عزيزي.
نشرف حضورك دكتور، نشرف حضورك حبيبي.
على راسي دكتور، الله يحفظكم وشكرا جزيلا.
الله يحفظك. دكتور مصطفى العفو.
بارك الله فيك، شكرا جزيلا. الآن ننتقل إلى المتحدث الأستاذ الدكتور محمد عبد الحسين أبو صيبع، اللي موضوع دراسته على metformin effects on markers of glycemic index and serum lipids in patients with type 2 diabetes on insulin therapy. تفضل دكتور سالم.
دكتور العفو، بس
حضرتك إذا ممكن تقرأ
العفو دكتور، بس ردنا الدكتور يرفع ايده حتى ندخله كهوست ويانا اذا يسمعنا.
تفضل
دكتور تسمعني؟ دكتور مصطفى تسمعني؟
ابو
دكتور تسمعني العفو؟
واضح دكتور.
دا اسمع دكتور اذا ممكن
صوتك. اذا ممكن دكتور محمد رايز هاند حتى
دكتور اعتقد نستخدم فيديو استاذ عدي.
هسه راح اشيره دكتور، لحظه واحده.
اعتقد دكتور محمد ما موجود يعني، لان كان راسلنا لو موجود.
ثواني دكتور.
دكتور سالم اذا ممكن
راح القي
السيره الذاتيه
حتى نشير ان شاء الله تعالى. ان شاء الله
الاستاذ الدكتور محمد
ان شاء الله تعالى. الاستاذ الدكتور محمد عبد الحسين ابو صيبع حاصل على شهاده البكالوريوس في الطب، شهاده الدبلوم في الطب الباطني، وكذلك شهاده البورد العربي في الطب الباطني. استاذ في الطب الباطني جامعه الكوفه كليه الطب، طبيب استشاري في وزاره الصحه، المدير المناوب لمركز الغدد الصم والسمنه في النجف، وهو زميل الكليه الملكيه في ادنبرا. لديه العديد من البحوث في مجال اختصاصه.
السلام عليكم. Our subject is metformin effects on markers of glycemic index and serum lipids in patients with type 2 diabetes mellitus on insulin therapy. Type 2 diabetes mellitus is a chronic metabolic condition characterized by persistent hyperglycemia due to insulin resistant, impaired insulin secretion, and decreased and help to further reduce glucose level. Besides, it can also affect the liver metabolism of glucose, thereby less glucose is released to the peripheral tissue. Enhance fatty acid oxidation and less glucose absorption. Studies have showed that the type 2 diabetes mellitus patient have 3 times higher gluconeogenesis rate as compared to the healthy individuals. Metformin treatment reduced by over 1/3. Studies have investigated additional effect of metformin on serum lipids and cardiovascular markers with loss of contravascular outcome. The aim of this study is to show beneficial effect of using insulin therapy with metformin on glycemic index and serum lipid in patients with type 2 diabetes. Methodology. A random clinical trial which include 50 participants with a clinical diagnosis of type 2 diabetes mellitus on insulin therapy without metformin. Participants were recruited at the Diabetic Center in Al Sadr Medical City in النجف, الاشرف. This study was reviewed and approved by Human Research Ethics Committee, Faculty of Medicine and University of Kufa. Participants were between 35 to 70 years, currently on insulin therapy and hemoglobin A1C more than 7%, and high serum lipids. Patients were excluded from this study if they have a proven renal failure, heart failure, liver impairment, and or diabetic complication, for example, unhealed diabetic food. Participants received azofine insulin and soluble insulin injection twice daily. Metformin supplement was added to the maximum dose 2000 mg per day and follow up for 3 months. Orthometric parameters such as body weight, waist circumference, height, and body mass index, serum lipid profile, for example, total cholesterol, triglyceride, high-density lipoprotein, and low-density lipoprotein, glycemic marker, blood glucose levels, insulin, and hemoglobin A1C, as well as blood pressure. Statistical analysis data were analyzed use mean plus minus standard deviation of the mean using p-value less than 0.05 can be significant. This is the cutoff value. And per t-test with 95% confidence interval was used to compare the mean of the variable prior and following metformin treatment. Data were analyzed using statistical analysis software SPSS IBM version 14. The result in table 1 show the marker of glycemic index before and after metformin, significant p-value. And in this study, about 30% of hemoglobin A1C is less than 7%, and 50% of hemoglobin A1C in between 7 and 8%, and 20% had high hemoglobin A1C more than 8%. In table 3, compare between male and female before and after treatment of metformin in type 2 diabetes mellitus. And in this study, plasma triglyceride were significantly reduced, followed at 3 months metformin therapy, and something which could not be visualized by the remaining serum lipid profile. Waist circumference was significantly reduced following metformin therapy, and something which could be not seen in other arthrometric markers. And person correlation indicate that the reduction in hemoglobin A1C were independent on the reduction in the waist circumference and body mass index. However, a small correlation was noticed between the reduction in TG and body mass index, TG and waist circumference. In discussion, because of the various metabolic complications of type 2 diabetes, consideration should be given to monitor glycemic marker, serum lipids, body weight, as well as blood pressure. Following the proved effect of metformin on hyperglycemia, studies have focuses on the other beneficial effect of metformin on serum lipid, weight, and blood pressure. And this study illustrated that metformin was very beneficial in improving markers of glycemia in terms of significant reduction in hemoglobin A1C and blood glucose level. And these findings agree with other studies. For example, Duke IF et al. In a double-blind randomized placebo-controlled trial study continuing metformin when starting insulin in patients with type 2 diabetes. Over 12 months, metformin was associated with a greater reduction in hemoglobin A1C and a level insulin requirement, and with lower insulin requirement. Plasma level of triglyceride were significantly decreased in this study following metformin introduction, although there was an elevation in HDL cholesterol and decrease in total cholesterol. But its value was not statistically significant. Studies have reported that metformin can increase triglyceride clearance by brown adipose tissue in animal model, mice, for example. Other study had controversial outcome with regards to the metformin effect on serum lipid. The United Kingdom prospective diabetes study reported a reduction in TG level, but other study reported an overall reduction in all markers of serum lipids. One potential justification for the variation in the data may be related to the difference in the clinical setting and low sample size. In current study, there was a significant reduction in waist circumference, while body mass index was insignificant, and there are an agreement with other study who reported similar correlation between reduction in the body mass index and body weight in response to the metformin therapy. Bailey et al. In 2009 study the effect of metformin on body weight and waist circumference in the diabetes prevention program outcome study and instituted by Rockville MD during the first 2 years of the double-blind phase. Body weight decreased more in the metformin than in a placebo group. An early dose-related reduction in waist circumference is also can be seen. According to the Duke IF et al. Study, in a double-blind randomized placebo-controlled trial study that continued metformin when starting insulin patients with type 2 diabetes. Over 12 months, metformin was associated with less weight changes than placebo, with significant decrease in waist circumference. In conclusion, the combination of metformin and insulin showed beneficial effect as a marker of glycemic index and triglycerides in patients with type 2 diabetes mellitus. In addition, there was a significant reduction in waist circumference with minimal changes to the high-density lipoprotein and the blood pressure. Thank you.
شكرا دكتور سالم على عرض التسجيل. كنا نتمنى بالحقيقة موجود دكتور الأستاذ الدكتور محمد أبو صيبع للاستفسار من عنده ببعض النقاط المهمة بخصوص التايب 2 دايابيتس واستخدام الانسولين، خاصة عند المرضى اللي عندهم تايب 2 دايابيتس وماضي عليهم أكثر من 5 سنوات. بالعادة يصير ديكلاين بالبيتا سيلز هذا الديكلاين بالبيتا سيل برودكشن يحتاج انه بعض المرضى اللي هم مصابين او عندهم تايب 2 دايابيتس يحتاج انهم انسولين ثيرابي. على كل حال اي شخص من الاخوه والاخوات اللي موجودين بالزوم معنا اذا كان عنده اي استفسار او سؤال بخصوص موضوع اللي قدمه ان الاستاذ الدكتور محمد عبد الحسين ارساله لنا واحنا بدورنا نرسل الاسئله للاجابه عنها. شكرا دكتور سالم على عرض التسجيل الخاص بالاستاذ الدكتور. دكتور سالم عفوا تسمعني؟
بلي دكتور بلي تفضل.
ننتقل إلى المتحدث السادس اللي هو الأستاذ المساعد الدكتور هادي جبر. تحدث لنا الأستاذ المساعد الدكتور هادي جبر Epidemiological Characterization of COVID-19 Confirmed Cases in ديوانية Governorate. تفضل دكتور سالم إذا حضرتك ممكن تقرأ السيرة الذاتية.
شكرا جزيلا السيد رئيس الجلسة. بدءا خلف الكواليس استاذ عدي هو اللي يشير واللي يرتب بصراحة مو أنا.
خدمتكم دكتور.
الله يحفظكم.
شكرا جزيلا للجميع لكل المشاركين سواء ذكرنا اسمائهم او ما ذكرناها، كل الجهود مباركه.
الله يحفظكم دكتور. نشرف بتعريف الدكتور هادي، الاستاذ المساعد الدكتور هادي جبر السهيل اللهيبي، بكالوريوس طب عام، حاصل على الماجستير والدكتوراه في طب المجتمع، مقرر فرع صحة المجتمع منذ عام 2013 لحد الآن، ولديه العديد من البحوث في مجال اختصاصه. يتفضل الدكتور هادي يشرفنا بمحاضرته.
دكتور هادي عفوا لك متسع من الوقت، يعني احنا عندنا مجال.
وعليكم السلام دكتور. بس الصوت ناصي دكتور هادي.
دكتور هادي
الظاهر النت عندي ضعيف.
دكتور هادي عفوا
حاليا واضح دكتور.
من الوقت اذا حضرتك تاخذ راحتك بتقديم الدراسه اللي تخصك. تفضل.
دكتور تسمعوني؟ العفو.
تفضل دكتور، المايك لك، صوتك واضح جدا جدا.
شكرا جزيلا. بسم الله الرحمن الرحيم. يشرفني أن أكون أحد أعضاء هذا المؤتمر الكريم وتحت اسم الكفيل، فشكرا لكم لاستضافتي وشكرا لكم لاستماعي وشكرا لمن دعاني الأخ الأستاذ المساعد الدكتور سعد مشكور عميد كلية الصيدلة في جامعة الكفيل المحترم. الحقيقة موضوعي أنا هو دراسة بسيطة وعدت من قبل دائرة الصحة، وأنا كنت أحد أعضاء اللجنة الاستشارية للسيد رئيس جامعة القادسية، لأن هو كان أحد أعضاء لجنة المتابعة الكوفيد 19 في الديوانية مع مدير عام الصحة مع قائد الشرطة، فكنا نجمع الإحصائيات والمعلومات يوميا وبعدين قدرنا أن نوثقها ونجمعها. فسويت الدراسة بسيطة اسمها Demographic and Epidemiological Characterization of COVID-19 Confirmed Cases in ديوانية Governorate 2020. حقيقة all of you know that the first confirmed COVID-19 case reported in Iraq was in Najaf Governorate on February 2020. Soon later, Iraqi cities have witnessed a significant increase in the reported cases. Among them is the Diwaniyya Governorate, in which there were 13,246 total cases were reported on the 25th of September 2020. The cure rate was about 78%, 169 deaths, and 10,676 recovered patients. Despite the healthcare interventions performed by the medical staff of the governorate, particularly the public health authorities in the Diwaniyya Governorate, there has been a dramatically increased report cases. ورا مجمعنا هذه المعلومات حقيقة لهذا التاريخ، فصار عندنا فد غرض من الدراسة. The aim of this study at introducing comprehensive study and epidemiological characterization of COVID-19 reported cases in Diwaniyya Governorate. هذني الأرقام اللي سجلناهن حقيقة سوينا في الدراسة عليهن، نعرف منو هم، شنو هم، منو الأكثر عرضة، منو الأكثر معرضين للوفيات، منو الأكثر معرضين للإصابة بالمرض. So we study involved descriptive analysis of COVID-19 confirmed cases reported in Diwaniyya Governorate from 24 February 2020 to 25 September 2020. The analysis involved epidemiological and demographic characterization of confirmed cases. And then we studied the epidemiological and demographic of those confirmed cases. Data were kindly obtained from the Directorate of Health in Diwaniyya. Our result was the highest prevalence was reported in the city center, followed by Shamia district, Al-Hamza district, and Afak district respectively. In terms of gender, about 48% of confirmed patients were females and about 52% were males, with death rate of about 1.4%, 1.8% in females and males respectively. The age group in most cases was between 16 and 44 years, where the highest incidence, 52%. In addition, 8% of reported cases were in children under 15 years old. About 5% of cases were among healthcare workers. Highlighting and reconsider COVID-19 spread in Diwaniyya, and increase the awareness of our community and establish a baseline data for future studies. The methods we used collect the data used in this article were obtained from the official records of the epidemic unit at the Department of Public Health in Diwaniyya province. Data for other governorates were obtained from the official records of the Ministry of Health in order to do comparison. Data collected in this study covered cases reported in the first 7 months of the epidemic. Additional sources were also viewed to verify the accuracy of numbers reported. Data were analyzed using statistical package for social science version 20. For Diwaniyya Governorate, only the total number of cases and their fate could be obtained. For Diwaniyya cases, data on age, sex, residence, fate of the case, history of travel, and presence of comorbidity were obtained. Data on population of Iraqi governorates were based on official document issues by the Iraqi Ministry of Planning. The subject of this article was part of a research proposal approved by the Central Research Committee at the Directorate General for Health in Diwaniyya. شلون وصلنا إلى تشخيص COVID-19 case. A case of COVID-19 denotes a person who presents to any designated health institutions with symptoms suggestive of COVID-19. يجي suggestion and confirmed by clinical picture plus CT scan of the chest, nasal or oral swab polymerase chain reaction test PCR. بهذين الحالات كلهن يلا نقدر نثبت إذا طلع PCR positive. CT scan مرات يطلع 50% of involvement of chest of lungs. So we say that this is a COVID-19 positive. In this study, we followed the reporting guidelines for strengthening the reporting of observational study in epidemiology. Characterization of patients and demographic pattern of distribution as a result of our study. There were 13,246 confirmed cases confirmed positive to COVID-19, which represented a substantial cumulative increment from the 24 February 2020, when the first case was reported, until 25 September 2020. It was shown that most patients tested positive for COVID-19 were with the age of 16 to 44 years. In addition, it was revealed that 8% of patients were children under 15 years old. Furthermore, it was significant that the fatality rate is increasing with age. For example, it's higher in patients with age of 60 to 80 years. In terms of gender, about 48% of confirmed patients were female, and about 52% were males, with death rate about 1.4% and 1.8% in females and respectively. The highest district and affected district respectively. Among health workers, it was shown that 205 healthcare workers were among infected people, a number which accounts for 5% of the total confirmed cases. About 80% of cases were reported in the city center, and about 60% of total cases among healthcare workers were nursing staff members, and 30% were medical staff members. Sorry.
تفضل دكتور هادي، كمل. تفضل حضرتك.
شوية بس صار عندي في التلكؤ بالحاسبة.
ماكو مشكلة، على راحتك. على راحتك.
Okay. Discussion. The article was intended to document the salient features of the epidemic in Diwaniyah within the national context, and to document that the scale of this epidemic is modest for reasons which are not clear yet. The management of epidemic was guided by the Ministry of Health guidelines issued by the National Task Force and also by local task force at the level of Diwaniyah province. The guidance encompasses directives to the healthcare providers. أول شيء, we are guided for healthcare providers, the public, and other local agencies. The prime objectives of our study were يعني الغاية من الإحصائيات والدراسات. Prime objectives were to eliminate source of infection, interrupt transmission, and protect the healthcare providers and also the public from the. In addition, the highest possible quality of care is provided to confirmed cases of COVID-19 infection. إذا نمنع الانتشار، نمنع المرضى، و in addition the highest possible quality of care is provided to confirmed cases of COVID-19 infection. Social distances and other protective measures could have contributed to the low scale of the epidemic in Diwaniyah. With respect to patients' characteristics, they were almost equally distributed by gender, with a median age of 45 years, and no case was reported in children less than 10 years. These results tend to agree with the prevailing view that COVID-19 a low risk or mild disease in children. These features were similar to what was reported on COVID-19 cases in Singapore and China. Within the province of Diwaniyah, the cases were distributed in a sporadic manner. No specific district or location could be identified with high number of cases. The initial small number of cases could be traced to have visited countries with COVID epidemic, but most of the cases were either contacts to initial cases or they were solo cases at the time and the place. Solo يعني فد حالات منفردة. Both the incidence and fatality rate were a little bit higher in males than female. The incidence was 52% in males and 48% in female, ratio 1.2 to 1, while the fatality rate was 68% in males and 32% in females. Findings which are consistent with the previous study in regards to gender-related incidence. Although the gender-related incidence has been reported to be 50-50 in most countries such as Italy, Scotland, Switzerland, Sweden, Belgium, higher incidence in male has been reported in Iran, Costa Rica, Thailand, Greece, Pakistan, and Mexico. According to our data, COVID-19 incidence was in all age groups, with the highest prevalence among patients with age 16 to 45 years. These findings are consistent with the previous studies. The high incidence in this age group could be due to the fact that people in this age group are involved in most activities of life. In terms of fatality rate, it was the highest among people with the age of equal or more than 60 years. It is most common that this patients group or this patient group had underlying disease conditions such as diabetes, obesity, cardiovascular, and lung diseases. Despite this death rate, a considerable number of elderly patients were cured due to their job in direct fighting against disease. Our healthcare workers are more susceptible to be infected with possible transmission to their families. Finally, the conclusion of our study, our data showed that the incidence was higher in the middle age, in the city center, and the fatality rate was highest among elderly people. Further studies are needed to focus on comorbidities and clinical evaluation regarding the severity and disease course of COVID-19 in elderly. Collectively, our findings introduce a comprehensive understanding of the epidemiology and pattern of incidence of COVID-19 in Diwaniyah Governorate. Thank you for listening, and I am ready for any question.
Thank you very much دكتور هادي على التقديم الرائع. الحقيقة أنا عندي، إذا تسمح لي، عندي 3 استفسارات. Actually I have I would like to apply highlight on اللي هو منهم why has coronavirus, according to your opinion, why coronavirus affected cities more than rural areas?
حقيقة دكتور احنا الكراوديسيتي in the city is more than urban first. Second, distancing in rural area and the open environment play a role. And third, which is an important, I think, their vegetarian diet is better than the rich diet in cities.
وهاي نشوفها دكتور بمحافظاتنا، يعني اذا تشوف في شيء حالة
احنا الان
نشوفها موجوده.
دكتور هسه اشوف الاعلى بالنجف. ليش؟ هسه احنا محافظاتنا قارن بين الديوانيه والنجف، كل القراءات مال هالايام او مال الايام السابقه او اول حاله تصير بالنجف اكثر. ليش؟ لانه النجف الان ميناء دكتور. يعني الكراوديسيتي، انت اذا جنابك البارحه شفت مع حظر التجوال البارحه يوم 21/3، يعني الناس الموجودين بالنجف عبالك ماكو حظر تجوال وعبالك زياره ال40. فالاوفر كراوديسيتي بلاي رول، وكل واحد جاي من بيئه وكل واحد جاي من مكان، ويمكن مسافر، يمكن عنده فد هيدن انفكشن، ويمكن عنده مناعه وما مطلع على اعراض. فالكراوديسيتي بالمدن هي، ولذلك تشوف هسه الان انت بغداد والبصره والنجف هن التوب بكل القراءات اليوميه. نعم.
البصره اذا نشوفها دا تتصدر المحافظات، رايك دكتور قد تكون الوذر كونديشن او الاير بوليوشن قد ممكن تاثر على
بلاي رول دكتور. بس البصره اوبن على كل المكانات. يعني انت ميناء مقصر، الشركات النفطيه، العاملين الاجانب، الحدود الايرانيه، نعم قد تقول مغلقه بس هي ما مغلقه الان. التجار يروحون ويجون. البصره فد شيء، يعني فد شيء ما ممكن السيطره عليه بيئيا، بالاضافه الى الوذر مالتها اللي هي عاليه الرطوبه، الاجواء مالتها دائما تكون مختنقه. نعم دكتور.
نعم تمام. For how long دكتور it will be remain يعني هذا البانديميك؟ يعني احنا بالسارز تعرف جنابك السارز فيروس last for 8 months.
نعم.
What about COVID-19? For how long according your opinion it will be remain?
COVID-19 دكتور بعلم الله، يعني الان احنا هسه اذا جنابك مطلع الان على الابديت اوف فاكسينز دكتور.
نعم.
الابديتنج اوف فاكسينز الان الاسترازينيكا الموديرنا السينافورم then if they had been given to a lot of people 60-70% of people it will play a protective راح تنطينا فد هيرد immunity اللي هي مناعة مجتمع مناعة ناس إذا الناس التزمت بالتباعد الاجتماعي والتزمت بالتعليمات إذا الناس التزمت بالكمامة والابتعاد عن النفس وعن المصافحة وعن الملامسة هذا راح يشتغل بدور كبير وهو كأي فيروس ترى دكتور هو فيروس كورونا فيروس مو الآن موجود هو موجود بس الآن صار جائحة الآن صار epidemic صار بانديميك ليش؟ لأنه ما نعرف هالطفرة اللي صارت بيه السترينث اللي صار بيه وإلا هو مو الخلل بالناس الفيروس هو اجى بطريقة أخرى الفيروس اجى نوع آخر احنا
يعني هو
يمكن جناب
دكتور عندك فكرة عفوا عندك فكرة انه how did the virus
نعم.
start يعني regarding COVID-19
والدكتور عيد السؤال رجاء
how did the coronavirus start يعني البداية مال كورونا هي الميوتيشن اللي صارت بالفيروس يعني السارز وغيرها لو اكو فد وجهة نظر عند جنابه
والله دكتور هذا الموضوع يعني فد موضوع شائك حتى اذا جنابك تعرف قبل شهر WHO راحوا الى الصين حتى يدورون الاصل يردون يشوفون هاو ات ستارت
نعم
يعني نظريه المؤامره ونظريه التميوتيشن ونظريه الجنود الامريكان اللي جو من المانيا ونشروا في هالمكان وقبل فتره طلعوا في الطبيب امريكي نشتغل مع الصين وهيك مسوي فهذه فد بيها كونتروفيرسي يعني لحد الان ما حد ينطي فد شيء ستريت تقول هذا هو صار بميوتيشن هل هو فاعل هل هو من رب العالمين حتى يعني يهدئ الناس ويعقلها ويقول لها اقعدوا انتم هذا اقتصادكم كله نقدر نوقف فد مايكرو اورجانيزم ما ينشاف بالعين المجرده فبيها عده نظريات واحنا يعني انا الان كطبيب في الديوانيه او في النجف او في العراق او في اي مكان اخر ايش قد اقدر احصل على معلومات بها مصداقيه او دقه حتى اقدر اجاوب على هذا السؤال لا هم ينطون دقه ولا هم ينطون مصداقيه وحتى هسه الفاكسين دكتور اذا شوف هذا يقول سوى عندي خثره ذاك يقول ما سوى هذول بطلوا طلع طبيب قال ما يعني فد شيء بي تجاره وبي سياسه وبي العلم الان مثل التايه يعني احنا كاطباء يطلع لنا طبيب بيطري الان يقول هالشكل هذا يسوي ثاني يوم يعتذر يطلع واحد يقول وخروا الكمامه وتعالوا فحتى تخبط بالعلاج وتخبط بالمانجمنت اوف كيسز بس كبدايه دكتور كونتروفيرسي يعني لا انا ولا غيري يقدر يجاوب لك على هذا الموضوع
صحيح نتمنى ما عندنا غير التباعد ان شاء الله هذا
الوسائل
الوقائيه
الهيلث اديوكيشن دكتور
الفاكسين هو هذا املنا بالفاكسين
ان شاء الله ان شاء الله ان شاء الله
املنا
الله يحميكم ويحمي عوائلكم وان شاء الله ما تشوفون الا الخير ونلتقي على خير
يحفظ الجميع ان شاء الله
شكرا
جزيلا لتغطيتكم الموضوع المهم شكرا جزيلا الآن ننتقل إلى الباحثة دكتورة فاطمة محمد سعيد مهدي اللي حتتكلم لنا عن الإفكت أوف كوكيوتين فايبروسيس. دكتور سالم تفضل حضرتك إذا ممكن تقرأ لنا السيرة الذاتية للدكتورة فاطمة.
شكرا جزيلا سيد رئيس الجلسة. دكتورة فاطمة محمد سعيد بكالوريوس صيدلة من جامعة كربلاء عام 2014 ماجستير أدوية وسموم من كلية الصيدلة الجامعة المستنصرية عام 2020 الدكتورة سابقا موظفة في وزارة الصحة وحاليا هي مدرس مساعد في جامعة الزهراء كلية الصيدلة. تتفضل الدكتورة مشكورة.
شكرا جزيلا على التقديم. راح أقدم لكم بحث بعنوان Effect of CoQ10 and Candidate on male rats with pulmonary fibrosis on behalf of Professor Dr. Mustafa Ghazi Al-Abbasi and Dr. Muthanna Ibrahim Al-Azdi, who supervised this research. Pulmonary fibrosis is a disease refractory to treatment and carries a high mortality rate. It is characterized by scar formation, which leads to organ malfunction and death from respiratory failure. The first treatment studied in this research is CoQ10. It is an endogenous molecule, which is a part of the electron transport chain, as well as an important antioxidant enzyme in the body. Choosing CoQ10 is because of the oxidative stress aspect of pulmonary fibrosis. The second treatment used in this study is candesartan. It is an angiotensin II type 1 receptor selective antagonist. It is widely used in treating hypertension, and it was found that angiotensin pathway is widely involved in pulmonary fibrosis development. It promotes transforming growth factor beta-1 synthesis, which plays a key role in the fibrosis process. The studied parameters is interleukin-1 beta, tumor necrosis factor alpha, and histopathological analysis using trichrome stain. The objective of this study is evaluating the potential protective and therapeutic effects of CoQ10 and candesartan in pulmonary fibrosis. The research process begins with animal grouping, followed by pre-treatment with candesartan and CoQ10, after which pulmonary fibrosis is induced. The next step involves follow-up treatment with candesartan and CoQ10, and finally, samples are collected for evaluation. Grouping of the study: 48 male Weiser rats were randomly allocated into 4 groups, each consisting of 12 male rats. Methodology: the first group, which is the control group, received single injection of normal saline via the intratracheal route. The second group, the bleomycin group, received bleomycin as sulfate salt dissolved in normal saline as a single dose for the intratracheal route. The third group, which is the bleomycin and the CoQ10 group, received the bleomycin in the intratracheal route, as well as 100 milligram per kg of CoQ10 per day, orally for 5 days before and 10 days after bleomycin injection. The final group, which is the bleomycin plus the candesartan group, received bleomycin as an intratracheal instillation concomitant with 10 milligrams per kg candesartan per day orally for 5 days before and 10 days after bleomycin injection. The induction process. The induction was done by making an incision into the trachea and installing bleomycin as a single injection, while the rats were under anesthesia using ketamine and xylazine, after which the incision is sutured and iodine was applied. These pictures show the induction process. The result of this study in regards to the interleukin-1 beta serum levels, the levels were significantly elevated in the bleomycin group compared to the other groups. In regards to the control group and the third group, CoQ10 and the candesartan group, there was no significant difference. As for the tumor necrosis factor alpha, the results showed a significant elevation of the serum levels in the bleomycin group compared to the other groups, whereas there was no significant difference between the control group and the CoQ10 and candesartan group. In the histological analysis, it can be noted that picture A, which is the control group, show a normal pulmonary tissue, while picture B, the bleomycin group, shows fibrosis appearing in a blue color. In picture C, which represents the CoQ10 group, there is a mild fibrosis, also represented by blue color. And in picture D, which represents the candesartan group, there is also mild fibrosis represented by blue color. In conclusion, it could be said that both candesartan and CoQ10 decrease bleomycin-induced pulmonary fibrosis. Thank you for listening. If you have any questions, I will answer them.
شكرا جزيلا دكتورة فاطمة على النايس برزنتيشن. تفضل دكتور سالم.
شكرا جزيلا دكتورة فاطمة.
العفو دكتور.
بصراحة يعني باعتباري العفو دكتور مصطفى، ممكن أسأل يعني؟
تفضل دكتور تفضل.
الله يحفظك دكتور العزيز. باعتباري اخذ كانديسارتان فيعني this subject is interesting for me. السؤال ممكن العفو اكو مصدر للكيو كوانزيم كيو 10؟ اكو مصدر طبيعي له؟
مصدر جينيوس موجود بالجسم، يعني هو جسم اوتوماتيكيا يصنعه.
قصدي يعني كاكزوجينوس؟
اكيد اكو اكزوجينيوس.
قصدي مثلا واحد ياكل فد شيء مثلا زوله، قصدي مثلا يعني فد سورس.
ما عندي معلومة عن سورس معين، ولكن أعرف إنه كل الكائنات الحية هي أوتوماتيكيا العفو تفرز الكوكيوتين، فأتصور إذا هم يردون يستخرجوا من مصدر حي، بس ما عندي علم يا مصدر يستخدمون. أعتذر من عندك.
العفو ترى العفو. ترى بالنسبة يعني الكوانزيم كيو 10 بالنسبة للهايبرتنشن
بلي
ممكن يكون له دور؟
بلي عنده protective role على الهارت in general والcirculatory system.
يعني ممكن تكون ميكانيزم قريب على الكانسرتان لو مختلفة.
حقيقة أنا ببحثي ما لقيت ميكانيزم يشتغل على الانجيوتنسين باثوي، بس هو كأنتي أوكسيدنت يعني هو له أدوار مختلفة. يعني شفت أنه موجود ضمن الأمراض مال الجهاز القلبي، موجود ضمن أمراض العفو جهاز العصبي، وبقية أمراض مثل الشيخوخة وكذا. كل الأمراض اللي إلها فد يعني خلينا نقول الأساس مالتها الأوكسيديتيف ستريس، الكوكيوتين يعني له دور بها.
يعني كأنتي أوكسيدنت. بالضبط
كأنتي أوكسيدنت.
تمام دكتور تمام. شكرا جزيلا دكتور عزيزك.
العفو.
الله يحفظك.
دكتور سالم عفوا بخصوص السورسز اوف كوكيوتين.
بلى دكتور.
حضرتك سألت على هذا الموضوع تمام؟
بلى اي والله.
موجود بالمسل ميتس، موجود بالهارت، بالليفر، بالكدني، موجود بالفاتي فيش. الفيجيتابلز هم تحتوي على الكوكيوتين، الفروتس، الناتس والسيدز مثل السمسم هم يحتوي على الكوكيوتين. كل هاي ممكن يحصلها الشخص اللي يحتاج هذا النوع من الانتي اوكسيدنتس، ممكن تعوضه عن الكوكيوتين اذا ما راد ياخذها على شكل يعني as natural product as tablets or tablets.
تمام دكتور تمام. شكرا جزيلا.
شكرا جزيلا دكتور سالم على مداخلاتك. شكرا دكتورة فاطمة على البرزنتيشن. ننتقل إلى الأستاذ الدكتور صاحب يحيى المرشدي اللي حيتحدث على comparison the levels of hydrogen peroxide and glutathione in seminal plasma and ISCKU outcomes between male factor and unexplained infertile couples. تفضل دكتور سالم لقراءة السيرة الذاتية للأستاذ الدكتور صاحب يحيى حسن المرشدي.
الدكتور شكرا جزيلا دكتور مصطفى. أستاذ الدكتور صاحب يحيى حسن المرشدي أستاذ في الفسيولوجيا التكاثرية في جامعة الكوفة كلية العلوم قسم التحليلات المرضية. لديه بحوث منشورة في الفسيولوجيا التكاثرية، أحد أعضاء فريق معالجة العقم في مراكز النجف الاشرف، ولديه العديد من البحوث. يتفضل الدكتور مشكورا.
عفوا دكتور، صاحب المايك إذا ممكن، صوت ماكو.
الآن صوت دكتور تسمع واضح؟
تفضل دكتور، الصوت واضح جدا جدا، شكرا جزيلا.
بسم الله الرحمن الرحيم. السلام عليكم. شكرا جزيلا لكل الجهود التي بذلت من أجل إنجاح هذا المؤتمر، وهو الحقيقة المؤتمر هذا إن جميعا يعني وإن شاء الله مؤتمر مبارك، وإن شاء الله الجهود المبذولة مشكورة. وأقدم شكري أيضا خصوصا للدكتور مصطفى والدكتور سلام. Title of research or title of study comparison the levels of hydrogen peroxide and glutathione in seminal plasma and ISCKU outcomes between the male factor and unexplained infertile couples. Aim of the study is to compare the ISCKU outcomes and to evaluate the levels of hydrogen peroxide and glutathione in seminal plasma between male factor and unexplained infertile patient. يعني عندنا مجموعتين هنا، male factor وعندنا unexplained، وcomparison between them in ISCKU outcome and the hydrogen peroxide and glutathione. Patient and methods. Prospective study was done in fertility department at Al-Sadr Hospital from November 2015 to November 2016. The total samples are 79 couples divided into two classes. The first group, 66 patients, have male factor reason of infertility, while the second group, 13 patients with unexplained cause of infertility. Semen analysis was conducted according to WHO 2010 report. Sperm concentration, progressive motility percent, and normal sperm morphology percent were recorded. So hydrogen peroxide and glutathione levels were determined in seminal plasma by ELISA special kit. All women had long or short protocol to induce ovulation. ISCKU process was done and ISCKU outcomes were recorded. Fertilization rate, cleavage rate, pregnancy rate. The results. Let's start with the table. Number 1. Title, sperm parameters in male factor and unexplained group. Variables included sperm concentration, progressive motile sperm, sperm normal morphology, and the groups were male factor and unexplained group. The result revealed significant increase of sperm concentration, progressive motile sperm, sperm normal morphology in unexplained group compared to male factor. And the second table, major ISCKU outcomes in male factor and unexplained group. Variables involve number of mature oocyte, number of injected oocyte, number of fertilized 2PN oocyte, fertilization rate, cleavage rate, number of total embryos, number of grade 1 embryos, number of grade 2 embryos, number of grade 3 embryos. The groups are male factor and unexplained. All variables revealed not significant differences between two groups. except cleavage rate. Cleavage rate revealed significant increase in unexplained group compared to male factor. Table number 3. Glutathione and hydrogen peroxide levels in both male and unexplained infertility group. Variables in this table were hydrogen peroxide level, glutathione level, and male factor unexplained groups. In this table, we can to see there is an increase of hydrogen peroxide in male group and an increase of glutathione in unexplained group. This figure shows comparison between pregnancy rate of two groups, male factor and unexplained infertility. Unexplained had 30%, but in male factor group had 28. There is an increase in this group compared to male factor. Conclusion. From the result of the study, we can to conclude an increase of hydrogen peroxide and decrease of glutathione levels in male factor group, while there is decrease in hydrogen peroxide and an increase of glutathione levels in unexplained group that maybe was one of cause to increase cleavage rate and pregnancy rate in unexplained group compared to that in male factor group. Thanks for listening.
شكرا جزيلا لتقديمك دكتور. بما يخص المقارنة ما بين ال effectiveness of ISCKU versus conventional IVF regarding safety, regarding efficacy and success rate. Do you have an idea about
success rate in our fertility? In our country?
Yes.
30 to 40%. 30 to 40%.
دكتور الانتي اوكسيدنتس ممكن يفيد بهيك حالات الانفرتيليتي according to your study؟ انت حضرتك درست الليفل اوف جلوتاثيون مو تمام؟
نعم دكتور.
يعني برايك انه الانتي اوكسيدنتس ممكن تنطي فد ثيرابيوتيك اوتكمز بالانفرتيليتي؟
دكتور بالنسبه للانتي اوكسيدنت هسه عندنا بعض الحالات خصوصا هي المجموعه الانكسبليند جروب. الانكسبليند جروب دول شنو؟ الميل يكون نورمال من حيث الكرايتيريا، وبالنسبه للفيميل ايضا تكون نورمال، لكن هم ما يصير عندهم اطفال. بعدين احنا لاحظنا انه الانتي اوكسيدنت من ينطونه كسبلمنت للبيشنت هو الكرايتيريا مال السبيرم عنده مو فقط تتحسن، لا عنده حتى الدي ان اي اوف سبيرم الانتجريتي مالته تتحسن، وبالتالي النتائج مال الاكسي راح تكون افضل. وحتى بالمرضى الاخرين اللي هم مجاميع اخرى، يعني الميل فاكتور والمجاميع الاخرى من المرضى ايضا قبل لا يدخلون برنامج الاكسي عندما ياخذون انتي اوكسيدنت هم الريزلت عندهم تكون بالاكسي تكون افضل، وحتى مو بس فقط بالاكسي حتى بالناتشرال، يعني الناتشرال بريجنانسي ايضا يكون افضل.
يعني هسه تدخلوا حضراتكم اكثر من الكونفنشنال 1 تمام؟
نعم.
ماكو فد سبب يعني رئيسي لهذا يعني تفضيلكم للاكسي اكثر من الكونفنشنال؟ اكو فد اسباب يعني خاصه لو تخص السيفتي، تخص الافيكاسي، السكسس ريت لو اكو فد اسباب اخرى؟
هو دكتور بالنسبه للاكسي يستخدم لانه بعض المرضى عنده مشاكل مثلا بالنمبر اوف سبيرم. النمبر اوف سبيرم يكون قليل، ما يكفي حتى يوصل العدد الكافي حتى يوصل لليوترس ويسوي عمليه البنتريشن، يسوي عمليه الفرتلايزيشن. هذا نوع اخر لا عنده مشاكل بالسبيرم نفسه، اكو ديفكت بالسبيرم. احنا بالاكس شو نسوي؟
مورفولوجي
نسوي سيلكشن، نختار، عندنا جهاز خاص يسمونه جهاز الانفيرتد مايكروسكوب اكسي، هذا نسوي سيلكشن للسبيرم، نختار اللي يكون مور موتيليتي مور نورمال، الدي ان اي مالته يعني حسب الموتيليتي مالته هو يعني جود، فيكون اختيارنا افضل مما نخليه ناتشرال او كونفنشنال، لا يكون يعني اقل الريزلت مالته.
نعم. شكرا دكتور.
دكتور
سالم
سؤال دكتور العفو.
اي تفضل دكتور سالم، تفضل دكتور سالم.
العفو دكتورنا العزيز دكتور صاحب العفو.
تفضل دكتور تفضل.
الله يحفظكم. ممكن له علاقه بالجندر؟ يعني هذا ال H2O2 والجلوتاثيون ممكن له يعني علاقه بتحديد الجنس؟
طبعا هو الانتي اوكسيدنت والهيدروجين بيروكسيد. الهيدروجين بيروكسيد هو نوع من انواع الفري راديكالز معروف هذا يعني، والانتي اوكسيدنت فمن يصير اكو امبلس بين ذيم راح يصير عندنا اوكسيديتيف سترس. الاوكسيديتيف سترس ياثر على الموتيليتي اوف سبيرم، فشيء طبيعي يكون ياثر على هذا، ياثر على الجندر اكيد يعني.
تمام دكتور احسنتم،
شكرا دكتور صاحب، شكرا جزيلا.
الله يسلمك دكتور، شكرا جزيلا.
الآن ننتقل للبحث رقم 9 اللي تقدمه دكتورة رنا حسين قطيف حسون عن دراستها اللي تخص ال effects of raloxifene and their combination with pioglitazone on serum anti-malarian hormone levels in patients with PCOS. تفضل دكتور سالم لقراءة السيرة الذاتية للدكتورة رنا.
شكرا جزيلا سيد رئيس الجلسة. دكتورة رنا حسين قطيف حسون، بكالوريوس علوم صيدلة من جامعة بغداد عام 2001، ماجستير صيدلة سريرية كلية الصيدلة الجامعة المستنصرية عام 2015. عملت في مؤسسات وزارة الصحة من 2001 ولغاية 2017. دكتوراه صيدلة سريرية من كلية الصيدلة الجامعة المستنصرية عام 2021. لديها عدد من البحوث في مستوعبات عالمية، حاصلة على براءة اختراع عام 2017، وهي الآن مدرس مساعد ومقررة لقسم الصيدلة السريرية في قسم الصيدلة بشكل عام كلية التراث الجامعة. تفضل دكتورة ومشكورة مقدما. دكتورة رنا اسمعينا؟
اي نعم دكتور.
تفضل.
البرزنتيشن موجود يمكم دكتور؟
برزنتيشن؟
نعم
موجود. اذا استاذ عدي، اذا ممكن استاذ عدي.
دكتور عندنا الفيديو موجود وجاهز اذا تحبين نشيره.
استاذ عندنا برزنتيشن همين استاذ عدي.
واكو موجود البرزنتيشنز، ما ظاهر البرزنتيشن يمكم؟
هسه اشوف ثواني. انا
دكتورة شيري الباور مرة ثانية.
اوكي بس شيرت الباور. ظهر يمكم؟ عفوا دكتور.
ثواني دكتورة ثواني. ما ظهر دكتورة. سوي شير سكرين. يكون الباوربوينت مشتغل وبعدين تسوين شير سكرين.
دكتور افتح الباوربوينت خليه خلف الشاشة.
دكتورة رنا عرضي باوربوينت
ارجع للزوم دكتور، هسه ارجع للزوم.
احسنتي، الصورة واضحة بدون زوم، تقدرين تكملين دكتورة، بس افتحي المايك وكونتينيو.
دكتور بامكانك تستخدمين هاي الشاشة، يعني ماكو داعي حتى تشيرينه، بامكانك جاي نشوف هسه احنا.
دكتورة رنا صوت ماكو، استخدمي الكنترول يكون بأعلى الشاشة، اصعدي أعلى الشاشة. وسوي أنا ميوت. أنا راح أنطيك بيرميشن. أحسنتي كونتينيو دكتورة، بالتوفيق.
السلام عليكم. طبعا نشكر جامعة الكفيل اللي اتاحتنا هاي الفرصة إنه نعرض البحث مالتنا. نشكر كل العاملين على هذا البحث. My topics today about the effect of raloxifene and their combination with bioglitazone on serum anti-Mullerian hormone level in patients with resistant polycystic ovary syndrome by Rana Hussein and Dr. Mustafa Ghazi Al-Abbasi. Polycystic ovary syndrome was firstly discovered by Stein and Leventhal in 1935. For this reason, it was named as Stein-Leventhal syndrome. It is regarded as one of the most common endocrine disorders among women of childbearing age. Some women may be symptomatic and others are asymptomatic, influencing women's psychology, physically, endocrinologically, reproductively, and metabolically. Polycystic ovary is characterized by insulin resistance and hyperandrogenism and anovulations. Anti-Mullerian hormones is a polypeptide that belongs to the family of transforming growth factor beta, which is secreted by the granulosa cells of growing enteral and pre-enteral follicles. In women, serum was shown to be contained AMH levels during their reproductive life cycles, so there was a growing interest in the possible roles of the AMH as a predictor of ovarian functions and dysfunction in recent years. Clomiphene citrate was gold standard treatment for the polycystic ovary, but about approximately 20% of women with the PCOS failing to respond to maximum dose of the clomiphene and be considered resistant to these medications. Alternatives are restricted. Lately showed that the endometrium of women with the PCOS who receive clomiphene may have decreased the expression of some implantation-specific biomarker, like leukemia inhibitory factor. Raloxifene is a selective estrogen receptor modulator approved for treatment of the osteoporosis in postmenopausal women with the hypothalamus-like anti-estrogenic effect and or pituitary-like clomiphene and tamoxifen, and may have beneficial effect on endometrial respectivity marker compared to the clomiphene and tamoxifen. The aim of this study to evaluate the effect of raloxifene alone and their combinations with bioglitazone for 12 weeks on serum AMH levels in overweight women with resistant polycystic ovary.
Material and methods. This prospective study included 64 anovulatory women with the PCOS who referred to the Department of Obstetric and Gynecology at Al-Haj Jalal Hospital, Wasat, Iraq for ovulation induction. Women with the PCOS identify according to the Rotterdam criteria, which at least 2 of the 3 features must have. Women were between 18 to 37 years of age with primary or secondary infertility and PCOS seeking to be pregnant without history of ovulation induction at least 3 months ago. The patients were randomly divided into 2 groups. Group 1, including 32 patients treated with the raloxifene, 60 milligram oral tablet twice daily for 5 days, starting on 3rd day of the menses. Group 2 including 32 patients treated with the raloxifene, 60 milligram twice daily for 5 days each month, plus pioglitazone oral tablet 15 milligrams 1 per day for 1 week, followed by 2 tablets per day to complete 12 weeks. All patients were followed up for 3 cycles. Result. In this table, hormonal effect induced by raloxifene and their combination with pioglitazone in patients with the PCOS. The following treatment approach affecting on the fasting insulin, raloxifene produced no significant difference, while their combination produced highly significant difference. While the effect of raloxifene on the homeostatic module assessment for insulin resistance produced no significant difference, while their combinations produce highly significant difference. The effect of both treatment, raloxifene and their combination of follicular stimulations produce no significant difference in both groups. While the effect on the luteinizing hormone, raloxifene produced no significant effect, while their combination produced highly significant difference. The effect also of this treatment on the testosterone levels produced no significant difference of raloxifene and produced highly significant difference of their combinations. The effect of the anti-Mullerian hormone of both treatments, raloxifene and their combination, produce highly significant difference. Comparison of the means of the anti-Mullerian hormone by the ovulator status after treatment by raloxifene and their combination with the pioglitazone. 2 groups of treatment produce highly significant difference, but the percentage of change in group 1 is higher than in group 2. Conclusion, the serum anti-Mullerian hormone increase in overweight women with the PCOS after raloxifene and their combination therapy for 12 weeks of treatment. Anti-Mullerian hormone was useful to predict a patient response to treatment in women with the resistant PCOS. شكرا.
شكرا جزيلا دكتورة رنا على تقديم الدراسة. إذا أكو أسئلة من دكتور سالم أو من الحضور، تفضل دكتور سالم.
شكرا جزيلا دكتور مصطفى. بصراحة يعني بحث شيق، بس معلوماتي قليلة ما جاب بالي سؤال صراحة.
اوكي.
اوكي، إذا أكو أحد من الحضور يحب يقدم سؤال ما بالأسئلة. بالشات بوكس ماكو أسئلة، عفوا.
لحد الآن بس يعني ماكو سؤال، بس الرابط على الرابط يحكون.
إذن ختاما نشكر لكم مشاركتكم الفاعلة في الجلسة العلمية الثانية. أشكر جميع الحضور، أشكر السيد مقرر الجلسة، أشكر الأستاذ عدي، أشكر كل الحضور، كان من السيد رئيس الجامعة، المساعد، السادة المساعدين، السادة العمداء، رؤساء الفروع العلمية، كل الحضور. مع حفظ المقامات والألقاب العلمية. نتمنى للجميع كل التقدير والشكر والنجاح إن شاء الله لهم. وكذلك أود أنه أذكر بأن الجلسة الثالثة سوف تكون في الساعة 9 من صباح يوم غد، اللي هي تكون الجلسة الثالثة والأخيرة لمؤتمرنا الدولي الثالث، مؤتمر دولي لجامعة الكفيل. Finally, we thank you for your active participation in the third international conference, the second scientific session, and best wishes for all. Last session will be tomorrow morning at 9 a.m. Thank you for all.
Thank you very much.
شكرا جزيلا دكتور.
شكرا جزيلا دكتور.
أعزائنا ضيوفنا الأعزاء، نشكر حسن إصغائكم وحضوركم، وإن شاء الله غدا نلتقي في رحاب جامعة الكفيل كلية الصيدلة لحضور الجلسة الثالثة من مؤتمر جامعة الكفيل العالمي. وإن شاء الله الجلسة تكون منقولة ومدارة أيضا على منصة زوم واليوتيوب وباقي منصات التواصل الاجتماعي. شكرا جزيلا لحضوركم ونتمنى لكم التوفيق وإلى اللقاء.
مع السلامة أستاذ عديد، تعبناك وزحمناك ومشكور.
الله يحفظكم دكتور، جزاك الله خير. الله يسلمكم. شكرا جزيلا.
الله يحفظكم.